Hi, everyone. I am Dawn Eichenfield. I'm a pediatric dermatologist at UCSD and Rady Children's Hospital. I'm very excited to kick off tonight's virtual journal club that's hosted by the SPT and Pedra. Our format today is to have a Q&A after each presentation, so please put your questions in the Q&A box in Zoom and not the chat. First off, it is my pleasure to introduce Dr. Eickstaedt, who is currently a Mohs surgeon and dermatologist at Carey Skin Center in North Carolina. Prior to becoming a dermatologist, he was an assistant professor of medicine at Mayo Clinic College of Medicine and Science, and he currently helps to develop our AAD basic dermatology curriculum on nails. So please welcome him today, and we will be discussing his wonderful paper that was just published not too long ago, Paradoxical Psoriasiform Eruptions in Children Receiving Tumor Necrosis Factor A Inhibitors. Dr. Eickstaedt, are you able to share screen?
Can you hear me?
Yes, we can hear you.
Oh, goodness. This always happens, doesn't it? I apologize. If you'd like to maybe go with someone else, I don't know why I have my PowerPoint up, but I can't share it.
If you click at the bottom of the screen, do you see a share screen button?
Yeah, and maybe it works now. There we go. No matter how many times we do this, there's always some difficulty. Well, thank you very much, Dr. Eichenfield, for that introduction. I'm going to jump in, and our objectives to this paper was to characterize the clinical features and course of TNF-alpha-induced psoriasiform eruptions in children. It was a multi-center retrospective case series that went from 2000 to 2016 for the data collection period, and it included all children under the age of 18, obviously those who were started on TNF-alpha inhibitors for diseases other than psoriasis. And we collected a total of 103 cases of TNF-alpha-induced psoriasiform eruption. I'll call it PSO. The average age of our patients was about 14 years old, and inflammatory bowel disease was the most common indication, with 91% of cases of TNF-alpha PSO were due to IBD. And importantly, about 92% of patients had control of their primary disease, mainly IBD, during eruption of their initial TNF-alpha-induced psoriasiform eruption. On this table, we can see that there was an equal split between male and female. The vast majority did not have a history of psoriasis. And again, the vast majority were started on a TNF-alpha inhibitor for IBD, although this was one of the first studies to also include JIA, although there's another case that had it, along with a couple other esoteric etiologies. And then this is a breakdown of patients by which TNF-alpha they were on. So 65% were initially on infliximab, 34% were on adalimumab, and then there was one patient on certolizumab. My video keeps changing on me. So on average, it was about 18 months before PSO developed when patients were on a TNF-alpha inhibitor. About 83% of patients had eruptions at multiple sites. So scalp was the most common at 65%, but then this also included trunk, extremities, fingers, hands. And this figure did not make it into our final publication, but a lot of work was spent on it. So I thought I'd put it in here. It's a nice, colorful figure. For treatment, all patients were started on topical therapies, 92% of which were started on a topical steroid, and over half were started on greater than one topical therapy. In addition, 30% of patients were started on a systemic therapy, and these were to control their psoriasiform eruption, with 23% being put on methotrexate and 8% on steroids, and there were a couple that were put on other ones. And it took about 5.5 months of treatment with topicals and systemic therapies to lead to improvement or resolution of their psoriasiform eruption. And this is a flow chart, which I think kind of helps break it down and what happened with the patients. So we had 103 patients that developed psoriasiform eruptions on TNF-alpha inhibitors. And 65 patients were able to continue their TNF-alpha inhibitor with skin-directed treatment, which includes topicals and systemic therapies shown here, with over 2/3 improving on topicals alone. And then we also see over here that 26 patients were switched from their first line TNF-alpha inhibitor to a second line due to uncontrolled psoriasiform eruption, despite being on topicals and other systemics. And 38 total patients had to stop or change their initial TNF-alpha inhibitor. 25 patients were on infliximab, and 13 patients were on adalimumab when they had to change. And as mentioned, 25% switched to a secondary TNF-alpha inhibitor, of which 62% of them were started on adalimumab, 19% on infliximab, and then 20% were started on certolizumab. And with these changes, 88% of patients had improvement or resolution in their psoriasiform eruption in about 3.5 months. But during the course, we noted that 8 patients, or 31% of patients of this cohort, developed a secondary TNF-alpha inhibitor-induced psoriasiform eruption. And the way that we define this is that if the patient had clearance of all psoriasiform eruption, they were put on a secondary TNF-alpha inhibitor, and then at some point after that, they developed another psoriasiform eruption. We counted this as a second eruption. There was no difference among the 3 TNF-alpha inhibitors as to whether or not they would develop a secondary psoriasiform eruption. And the average time for them to develop the second eruption was about 8 months. And this was significantly shorter than the 18.5 months on their initial TNF-alpha inhibitor, although, again, this is a small sample size. And then in total, 18 patients, or 17% of the total patients that we identified, had to discontinue all TNF-alpha inhibitors due to their psoriasiform eruption. But 85% or 85 patients or 83% were able to continue on first or second line. There were 2 patients that were put on ustekinumab, and they had clearance of their psoriasiform eruption and did not develop any paradoxical psoriasiform eruption. And a similar effect was seen in the adult population as well in other papers published. So in conclusion, we would keep a suspicion out for any psoriasiform eruption in children placed on a TNF-alpha inhibitor for any indication, whether it be IBD or any other primary disease. There is likely a class effect among the TNF-alpha inhibitors, as we saw it with adalimumab, infliximab, and certolizumab. And then skin-directed therapies are effective in the majority of cases, which allows continuance of the TNF-alpha inhibitor, which is important because the vast majority of patients have control of their primary disease when on their TNF-alpha inhibitor. but you may need to consider discontinuing TNF-alpha inhibitors for recalcitrant traces of PSO. And then some of the limitations is that it's a retrospective study. These are all tertiary care centers. There was 8 of them, so there's a little bit of a selection bias. And we also had a small sample size, although it is not a frequent event. And I think open up to questions and discussion.
Thank you so much for sharing that paper. I really wish they let you include that first really colorful figure in the actual article. It's really beautiful.
We fought, but we lost. But I got to put it in here.
That's great. Thank you. So there's a couple of questions. The first, I will ask a few, and then I have one that's also from one of our other panelists. So where was the second TNF inhibitor-induced psoriasiform eruption on the skin? You said that their first one resolved and they got the second one. Was that one also on the scalp, or was that on a different part of the body?
It was the same breakdown. So a number of patients had it on the scalp. And then I think there's a few patients that had it on the extremities. There was no other site or new site. It did not occur per se on some special site.
Okay. And do you know, was there any insight about the morphology of these lesions? Were the morphology all papulosquamous, or were there other morphology sites that we are kind of classifying as the psoriasiform type reaction?
That was a debate that we had amongst the sites. We initially had it broken down into plaque, inverse, papulosquamous, or psoriasiform. But I think the conclusion of the consensus was that it doesn't quite look like standard psoriasis, and more kind of has this, psoriasis-like appearance to it. And so that's where we kind of made this general statement of psoriasiform instead of saying that 90% had plaque psoriasis.
Okay. I'm going to ask some questions from the audience. So the first question, they said, thanks for your study. I hope it will get us additional meds approved when trying to treat through TNF-induced eruptions. Was there any use of apremilast in the study to treat through?
There was no apremilast. I think we had methotrexate, oral corticosteroids for a taper, phototherapy. I think, let me go back. We had some phototherapy. I think a couple patients were put on LCD, but no apremilast.
Okay. Another attendee asked, I have noticed a possible increase in concurrent staph infection in the paradoxical psoriasis patients. Have you noticed this? They tend to have more oozing plaques on the scalp, and I've had multiple staph positive cultures in this setting.
We didn't specifically look at that or question the sites, although there were a handful of patients started on mupirocin ointment in addition to other treatments. And so, one could surmise that some of them did have staph, although again, I can't comment on numbers or how many of them may have been had superimposed staph infections.
Okay.
But definitely a good thought.
Yeah, I actually had one behind the ears when I cultured it up, and he got treated through with topicals, but when he did grow staph. It was interesting.
And I have this figure here, and for some reason, 34% of the patients had the post-auricular involvement. In one of our initial papers, we kind of highlighted that. I didn't highlight it in here, but it may be if you see, a psoriasiform-like eruption in the post-auricular area, and they're on a TNF-alpha inhibitor, maybe consider that.
Okay. And then Dr. Yu, who's one of our panelists, does have a question as well. He was wondering, did you see a difference in time to respond depending on what therapies they were put on? And he's asking because he has a patient with bad scalp psoriasis due to a TNF inhibitor, and he has been switched to ustekinumab, but he's still flaring after 3 or 4 months.
There was no, I don't know if there was any difference in response. Although I think when they were switched off of it, most people responded in about 3.5 months. But again, it did take up to 9 months. So I think some of them were a little more recalcitrant and required maybe a little longer time period. I hope that answers.
Thank you so much. Any other questions? Well, thank you so much, Dr. Eickstaedt, for joining us today. Next up, Dr. Grant Flost, who is from the University of Colorado, will introduce our next speaker and article.
Thank you, Dawn. I'm delighted to welcome our next two speakers who will be presenting their recent publication. Isabella Calvi is a recent graduate from the Immanuel Kant Baltic Federal University, and she'll be joined by Dr. Lais Lopez Almeida Gomes, who is a board-certified pediatric dermatologist in Brazil, who did her training at the University of Sao Paulo in Brazil. They'll be presenting their recent publication entitled Safety and Efficacy of Topical Nitric Oxide Releasing Berdazimer Gel for Molluscum Contagiosum Clearance, a systematic review and meta-analysis of randomized controlled trials. Thank you all for participating tonight. We look forward to hearing more about your publication.
Thank you.
Thank you.
Can you see my screen?
Yes.
Yeah.
Yes.
Thank you for the introduction and thank you for hearing me today. So I'm going to present this article with my colleague Isabella Calvi. Oops. The authors have no disclosures to report. And molluscum contagiosum is a dermatological infection caused by a contagious DNA virus transmitted through direct skin-to-skin contact. The infection is more frequent during childhood, and molluscum lesions typically resolve spontaneously in immunocompetent children. Molluscum carries an important clinical burden because of its appearance, the fast spread, generally intense pruritus, often leading to scratching and secondary bacterial infection. Several topical agents are commonly used for the treatment of molluscum, including silver nitrate, potassium hydroxide, and cantharidin. Berdazimer-free base gel 10.3% is a topical agent under investigation as a potential therapy for molluscum. This medication consists of berdazimer sodium macromolecules and hydrogel, capable of inducing nitric oxide release at the site of application. Nitric oxide has been shown in vitro to have antiviral activity by inhibiting viral replication and possibly promoting apoptosis of infected cells. Studies suggest this is the likely immune modulatory mechanism of berdazimer gel.
So thank you for the introduction. And speaking a little bit more about the methods and how we conduct our meta-analysis and systematic review, we decided to include only RCTs, so included studies that were randomized. As well, we included just children older than 6 months. Our main clinical outcomes were the clearance of the lesions at week 8 and 12, as we believe that because it's an infectious disease, the resolution should be done promptly because of its fast spread rate. In addition, we also evaluated the scarring rate, as the scars, of course, depending on the size and the area of the lesion, can cause in the future some psychological stigma for the child. You can pass. Thank you. Also, we evaluated some adverse events as erythema, exfoliation, pain, pruritus, dermatitis. All these adverse events, they are commonly seen in other topical therapies for MC's treatment, for mollusco contagious treatment. So here it's important for us to quantify how all these adverse events and their severity for each therapy can impact the child's health somehow. And the image that we see in the slide, it's an image that we're taking from one of the RCTs that was included in our meta-analysis. And in the first picture we can see a patient that was previously treated with bedazzaimer, and he presents a sign that is called both positive sign. And this sign, according to the article, means that the body is having like immune reaction to the virus. So it's like the beginning of the end. And they say that 18% of the child who were infected with mollusco contagious will have this immunologic reaction, regardless the use of the drug or even placebo, and etc. At week 12, the conclusion is that at week 12, the patients who were under the treatment with bedazzaimer, they have a higher incidence of the sign. So the article guides us to understand that the bedazzaimer will lead to this immunologic reaction and lead to decrease of the lesions count from the baseline. So therefore, we will have like a greatest reduction of the lesions count, and it also will shorten the duration of the infection. You can pass. Thank you. In this table, we can see the included studies. As I said before, we included 4 RCTs and 3 published articles. Our analysis included a total of 1,854 patients. All the studies were done in USA, and the intervention used was bedazzaimer 12%, but they are also known as bedazzaimer gel 10.3%, as in the last study. The control was the placebo or vehicle gel, and it's important here to highlight that many patients dropped out the study due to the loss of follow-up. You can pass. Here are the results of our meta-analysis. We use the Haveman tool to perform it. As we see in the first graphic, the rate of the complete clearance of all treated lesions at week 8 was higher among the patients who received the treatment with bedazzaimer when compared to the vehicle group. And similarly, the patients on the week 12 and the picture B also have a higher rate of complete clearance of the lesions. And as I said previously, we also analyzed the scoring rate, and it shows that bedazzaimer had a less rate, like a lower incidence in the group that were treated with bedazzaimer gel comparing to the placebo. And besides the main outcome, we also saw some adverse events, and all the adverse events, namely erythema, exfoliation, pruritus, dermatitis, and swelling, presented a higher rate comparing to placebo. You can. Yeah. And here we can see like a clear illustration of the benefits and risks of this new drug therapy. The benefit is the fast lesion clearance that was proven statistically. We had a significant number of lesions that were had the clearance, less scarring, so it's good when you speak about children's. But we have a lot of risks and a lot of adverse events like erythema, exfoliation, pain, and it should be weighed with caution when we speak about this population in question. You can pass.
So although molluscum can be self-limiting, the delay of the treatment may contribute to the spread of the disease. And cryotherapy and curettage are commonly used treatment options. Previous clinical trials with curettage showed the complete resolution of the papules with only one session, and 80.6% of the patients in the treatment group, and no recurrence after 6 months of follow-up. But on the other hand, curettage can be traumatizing for children, can cause pain. So we believe that there is still space for new therapies, like the berdazimer that we are presenting here. Berdazimer and cantharidin have been formally submitted for the FDA for FDA assessment as new drug applications. Cantharidin has been recently approved as a in-office drug, FDA approved by for an in-office drug application. And the problem with berdazimer is that there's no clinical trial data comparing the safety and efficacy of berdazimer gel with other treatment options, limiting the knowledge of the most effective and safest therapeutic approach for molluscum. So this meta-analysis included 1,854 patients and concluded the berdazimer gel has a higher rate of complete lesion clearance and decreased incidence of lesion scarring in the treatment of molluscum when compared with placebo, making berdazimer gel a promising potential therapy for children with molluscum. However, this therapy is also associated with a higher incidence on application site adverse events like swelling, dermatitis, pruritus, exfoliation, pain, and erythema. And the efficacy gains of this treatment must be carefully weighed against the potential safety risks. Thanks so much for listening us today.
Thank you both for the wonderful presentation. I'll start off with a question, and I think you alluded to sort of the FDA pursuit, but how will we be able to access the medication? Is there any idea of how much the medication will cost?
Yes, so
No.
we don't have an idea how much it's gonna cost, but we believe that it's close to be approved. So I think we're gonna have this information soon in the beginning of next year.
Question from the audience is the study dropout rate was very high, which makes the data conclusions hard to understand.
That's true. Yeah, a lot of kids dropped the study before, but we still thought that the data was worth to be shown, so we kept with the study. But that's true. Yeah, I think Isabella also mentioned that there was a high drop off.
Yes, we had
study.
a high drop of the follow-up, but we still had like a significantly number of patients that we could include it in the statistical analysis, and representing a good number when we plot this all information together. So besides the number of drop of the patients, we still have a good number to take a conclusion from the drug.
Were there any limitations in terms of patient age, who would be eligible or who was enrolled in these trials? How young, I guess, specifically?
They all the trials included children older than 6 months. That also was what we used to do our systematic review.
And then lastly, the endpoints of clearance at week 8 and week 12 to me seem ambitious, just in my clinical experience in treating molluscum. Thoughts on why there was such success, and how does that weigh against, all the side effects you guys have mentioned?
Could you repeat this question? So you think it's ambitious? You think it's too soon? Is that what you're thinking?
Well, yeah,
no.
I'm just saying, in my experience, it's such a challenging condition to clear, and 8 weeks seems fast.
Yes. Yeah, so there is a more recent publication in ours that they only considered week 12. So yeah, probably you are right. Probably it will need more, at least 4 weeks more to clear. But in the beginning, the trials were showing outcomes week 8 and week 12. But the most recent publication done by the authors of the trials, they made kind of an integrated analysis of all the trials together with the company, and they use it only week 12. So yeah, I think you are right.
And then last question before we move on, were there diverse skin types involved? Specifically, were there darker skin types in terms of the patients enrolled in the trials?
So it was something that we did not look at when we did our publication. I think we didn't have this data from the clinical trials that we look at, but the most recent publication done by the one that I've just mentioned, it cited the different skin tones, and the darkest skin tones had a lower response than the clear. How can I say it? Sorry. Yeah. Than the other skin tones. Yeah, darkest skin tones had a lower response.
All right, thank you all so much. I'll hand it over to Joy, who I think is introducing the next paper.
Great, thanks, Grant. So I have the pleasure of introducing our last paper presentation, which is going to be given by Hadley Johnson and Dr. Jeff Yu. Hadley is a fourth-year medical student at the University of Minnesota who is currently applying to dermatology residency. And she's been conducting research under the mentorship of Dr. Jeff Yu, who is a pediatric dermatologist at Massachusetts General Hospital and has a specialty focus in allergic contact dermatitis. So we're really excited to hear more about their recent study that is published in this month's JAD, describing the prevalence of allergic contact dermatitis in children with and without atopic dermatitis. So you guys can take it away.
Thank you. Can everybody see my screen? All right. So hello, everyone. Thank you for the introduction and thank you all for coming. My name is Hadley Johnson and I am a fourth-year medical student at the University of Minnesota. Today, I will be discussing my manuscript as titled here. A big thank you to all of the authors listed, including my mentor, Dr. Yu. Without their contributions, this project would not have been possible. So as many of you may know, allergic contact dermatitis and atopic dermatitis are two inflammatory skin conditions with similar clinical presentations, demonstrating red, itchy, eczema-like patches and plaques on the skin. The difficulty in distinguishing between these two conditions clinically may prevent referral of children to patch testing, as atopic dermatitis is often considered the primary diagnosis. This may lead to underdetection of allergic contact dermatitis. Whether children with atopic dermatitis are more or less likely to have allergic contact dermatitis than children without atopic dermatitis is also still largely unknown. Therefore, our aim was to evaluate the prevalence of allergic contact dermatitis in children with AD compared to those without, and to determine if there are particular allergens more commonly positive in children with AD. This was a retrospective study using data collected from 14 geographically diverse institutions located across all major regions of the United States. The study included pediatric patients referred for patch testing between 2018 and 2022. Providers performing the patch testing were physicians or advanced practice providers with experience in patch testing, as well as management of ACD. 912 children were included, 615 with AD, and 297 without AD. On these patients, we collected information on demographics, atopic history, location of dermatitis, allergen series utilized, positive results, and treatment history. Demographic-wise, the gender distribution between the two cohorts was statistically similar, with 38% boys and 62% girls. While most of the patients that were patch tested in the study identified as white, children with AD were more likely to identify as Black and less likely to identify as white than children without AD. Children with AD were also more likely to be patch tested at a younger age, at an average age of 11 years old, and were more likely to have atopic comorbidities, including asthma and allergic rhinitis. In terms of patch test results and ACD severity, the anatomic site of dermatitis was notably more generalized in children with AD. Children with AD who received patch testing were more likely to have more than one positive reaction and had a greater number of positive results overall, at an average of 2.3 positive patch tests per child. Children with AD had seen more providers and had a longer duration of rash than their counterparts without AD. The top 5 allergens in children with AD were nickel, MI, fragrance mix 1, cocamidopropylbetaine, and cobalt. Overall, this was quite similar to those without AD. However, children with AD were more likely to be positive to bacitracin, carbamix, and cocamidopropylbetaine. Some important limitations to this study include its multi-center nature, which could have introduced technical variation into the patch testing, as well as the potential for misclassification, selection, and recall biases. What to take home from the study is that children with AD develop more positive patch test reactions than children without AD. They are also more likely to react to certain allergens that are often used in the care of their skin, such as bacitracin, a topical antibiotic used for skin infections, and cocamidopropylbetaine, a surfactant used in gentle or tear-free skincare products. Ultimately, the results of this study underscore the need for children with AD to be referred to a specialist for patch testing, particularly when ACD is suspected, with an atypical distribution of the disease, or if the AD is refractory to standard therapies. Thank you all for listening, and with that, I will take any questions.
Wonderful. Thank you, Hadley. While we wait for questions to come in, I'll start with one. So I know you had sort of alluded to this already in the limitations and such. I'm curious if there is, potential for kind of like referral bias, right? Because these kids are getting referred for patch testing, and so perhaps those that have AD who get referred for patch testing are a little bit different than those with AD who don't get referred for patch testing. I was just wondering if you had any information in your data about sort of, features of the AD, or, what about the kids' AD sort of led to referral for patch testing? Was it that it was recalcitrant or, atypical or whatnot?
Yeah, definitely. Unfortunately, we did not collect information on the actual morphology of their rashes, but they were generally referred to our clinic either because they had an atypical distribution, such as hand, foot, or isolated eye rash, in addition to their normal atopic dermatitis sites, or they were not responding to the medications that should, feasibly treat atopic dermatitis.
Yeah. And then I guess the other question that I have is, it looked like in your results, right, kids with AD, they react to more, and you listed some of the more common allergens that they react to. I guess, how do your findings sort of, what did they tell us about how we should counsel, I guess, or patients with AD, who might not, who might just have typical AD, we're not too worried about allergic contact dermatitis, but, knowing sort of what are the most common allergens in those kids, like, are there certain, things that we should advise them to avoid, or, and
Yeah.
Dr., you could jump in here too, if you feel like.
Definitely. I think it's generally recommended for children with atopic dermatitis to use, hypoallergenic fragrance-free products, because many of the allergens that we found were fragrances. MI is another preservative that's found in a lot of personal care products. So using the lowest allergen products possible are probably generally recommended for these kids. And especially because we also saw bacitracin and neomycin in the top 5 allergens, we generally like to recommend the use of mupirocin if possible for those kiddos.
Right. Great.
Yeah,
all right.
I think,
We have go ahead.
Oh, sorry. I was just gonna say, I think one point I think that's important to drive home is that these allergens are going to change over time depending on the study you look at, depending on the region of the US you look at, or parts of the world. But I think the important thing to drive home here with kids with AD is that they're more likely to be sensitized to things that they use on their skin. Mostly, the theory at least is that they have a broken skin barrier, therefore their skin's a bit more permeable to certain types of smaller molecular weight haptens and things that may not typically sensitize a non-atopic kid or adult might actually sensitize a atopic kid. So I think, just like Hadley said, using lower allergen products, things that are devoid of fragrances, especially certain types of preservatives like MI, cocamidol, propylbetaine, topical antibiotics like bacitracin, I think those are kind of the things that I would definitely avoid in almost all my AD patients. Just if they're not already sensitized, they certainly stand a higher chance of being sensitized going forward.
Yeah, that's a great point of guidance. Thank you. And then we have a question sort of that's just a little bit more general. What is the youngest sort of age that a child can be patch tested, and any tips on doing patch testing in young children?
When I was with Jeff last year, I saw, month-old infants getting patch tested. I think a general recommendation is that they have a lower surface area to place the patch tested. So you definitely have to be selective with the allergens that you're placing. And then I don't know if you have any other recommendations, Jeff, on how to, best create an environment that they are comfortable with.
Yeah, I think that's tough. I think the biggest challenge in younger kids is you're not able to test them to nearly as many things as you want to in an adult. Like an older kid, like I saw some of those pictures that Hadley put up, even a 6-year-old, you can easily put on 80 things, and it fits comfortably on their back. If we really wanted to do more, we probably could. But I think we're really talking about the month-old, the neonates, the infants, that you can certainly still patch test. I think their immune system can still generate a type 4 hypersensitivity reaction. You just have to be really picky about what you put on. And you also have to think about the fact that their skin probably has a lower irritancy threshold, especially if they are atopics at baseline. So I would say, instead of leaving things on for 48 hours, typically the recommendation is taking them off after 24 hours of exposure, just to kind of decrease the likelihood of irritation, and then reading those patches after 48 hours of taking them off, so at 72 hours instead of the typical 96. And then lots of tape, give parents the tape, give the caretakers the tape so they can reinforce it at home if they want to, and then using clothing, ideally onesies or such, in really young kids so that they can't get to their back, they can't rip things off, because no matter, you can't tell a female bone not to scratch.
Great. And I guess one last question related to kind of, how best to interpret, some of the findings, right? Like, how in a kid who has underlying sort of atopy, they're probably more likely to get easily irritated and such. So any tips for, distinguishing between sort of true reaction versus irritation, or maybe even false positives, on patch testing in kids who have an underlying atopic disposition? Any thoughts and tips there?
Yeah, when I saw irritant reactions during my year, they typically were on the border, or they were just, a few dots here and there. We typically interpreted, a positive reaction as the typical square-shaped, elevated indurated rash. And then you also have to think about the relevance of the allergens that they're testing positive to. If they're not actually coming into contact with these allergens ever, it's important to know that, it's probably not causing their rash.
Great. And it looks like we have one last question that just came in. So did avoiding the positives, in your experience, make any difference in the atopic dermatitis? What has sort of, been shown?
Yeah, that's a great question. Actually, we're doing a follow-up study on that right now. We actually found that nearly 75% of our patients improved to some degree with avoidance of these allergens.
Great. Awesome. Well, we'll look forward to, seeing those results published.
Yeah, we pulled out, so we did a whole group analysis on adults and kids, and we pulled out the kids, and then we did a separate analysis. These are unpublished data, but they are submitted, where we're seeing, almost 75% in adults, about 80% in kids, with improvement. The ones that did not improve fully were the kids that had atopic derm, but I think that's also part of the message is that, you know, these kids with atopic derm that maybe has allergic contact dermatitis on top of it that comes into clinic, the last thing you should do is promise that you're going to cure their atopic derm, no matter how much their parents hope that you can do that. I always tell them we're going to be curing your allergic contact dermatitis. How much of your rash that's left over is truly atopic derm remains to be seen. But a lot of these kids at least do not completely improve, but they do mostly partially improve to a certain degree. So I think that's kind of the important message to make sure the parents know.
Great. Awesome. Well, thank you guys for that really helpful presentation and a lot of good learning points there. So I'll give the mic and screen back over to Dawn. I don't know if Dawn's there, but actually, you know what? We got another question. People are getting in their questions, like right under the wire here. All right, one last question for you, Hadley and Dr. Yu. Does Dupixent do anything if retested?
If I'm understanding this question correctly, it's asking if Dupixent has done anything for allergic contact dermatitis. And we have definitely seen that it improves rashes in people with contact dermatitis, even though the mechanism of action doesn't necessarily equate to that. And then I don't know if it's also referring to like if we're able to patch test patients on Dupixent, which we have generally been able to.
Great. All right, now I'm going to give the mic back over to our overall moderator, Dawn.
Okay, great. Thank you so much, everyone. I want to thank our fabulous speakers today for sharing their research with us, and our moderators, of course, for picking these articles, the SBD and PEDRA for hosting, and our audience for attending and asking such thoughtful questions. These journal clubs do happen quarterly, and we hope you can join us again. So have a great night, everyone.